honor to Gives me great honor and privilege to introduce who needs really no introduction, Dr. Robert Flora, who is the Chief Academic Officer and designated institutional official of McLaren Healthcare based in Ramblin. In addition to his multiple administrative and clinical responsibilities, he's also professor and associate chair for education in the Department of OBGYN and Reproductive Biology at Michigan State University College of Human Medicine. He's had a long and very well-established interest in the use of technology in medical education dating back to whatever that is, Atari and Commodore 128 days. He's board certified in OBGYN as well as female pelvic medicine and reconstructive surgery. He really utilizes to the utmost degree technology in the education of quality improvement and patient safety. And in 2006, he completed a graduate program in patient safety from the Virginia Commonwealth University. He's currently enrolled in the graduate certificate program in educational technology at Michigan State University. I don't know how he has so much time to do this. He's a faculty member for the AMC's Teaching for Quality Faculty Development Program. He's certified in Six Sigma and Lean through Villanova University. Multiple other board certifications include the Physician Executive, Public Health, and Quality Improvement. And on a personal note, he's probably one of the most effective quality improvement engagers and teachers that I've come across. He's an inspirational leader, and he's provided so much support and resources to this organization. He's taught me a lot, and he's really an encyclopedia of resources. So without further ado, Bob is going to be speaking about clarifying the CLER report, letting in some sunshine on a cloudy report. So Bob, take it away. Thank you very much.
Okay, thank you. Let me just get my slides here. Somebody nod. They're seeing my slides.
Yep, you're good.
Okay, great. Okay, clarifying the CLER report. And when we originally discussed this presentation, it was kind of after we read the CLER report, it was kind of a doom and gloom kind of feeling when we read it. But, after rereading it 2-3 times, and then really thinking about, what is the purpose of us doing this, then I think it did let in some sunshine and provided more opportunity. It provides us more opportunities to make it better. And I'll discuss with you what those opportunities are. So what I'm talking about today is the report that came out last year, the National Report of Findings 2021. There were 3 reports, 2016, 2018, and this one. And so it's been somewhat of an evolution and of the CLER purpose and the CLER results. But you really have to go back onto why are we on this journey? And this all started in 1910 when Flexner came out with his report. And basically, it was like the Wild Wild West in medical education. And it wasn't really based on science. And so that was the start of becoming very scientifically based, really following the German medical education model. In 1972, the Liaison Committee for Graduate Medical Education developed, which then about 9 years later became the ACGME. And then you started seeing this flurry of activity since then. So the position I currently held in 1998 was the start of the DIO, or designated institutional official, where somebody was responsible in the institution to make sure that we were compliant with the ACGME. In 1999, what they were finding was that physicians were too scientific based and not, quote, enough caring based. And so they came out with what's called the core competencies in what a well-trained quality physician should look like. And that's where professionalism, interpersonal professional skills, all those other competencies aside from the medical care and medical knowledge and patient care. They were trying to bring that back into the substance of being a physician. And so I started as a program director in '97, and I basically have lived through all of this. And it's quite an interesting journey. So the outcomes project was when we integrated the competencies. And then 2003 was really an interesting time because that's when the program directors had to introduce the 80-hour work week to all GME. And let me tell you, that was very, very interesting times. Then 2013, they came up with the next accreditation system and milestones. And the reason for that, and you won't see this written anywhere, but society, the United States, CMS was not happy with the product medical education was providing. And so there was some discussion about CMS taking over graduate medical education. And if you grew up in the 80s, you learned that government taking over anything is not a good thing. When they looked at how much the government pays for a hammer, it was like $200. So all we knew it was going to do was raise costs. So this next accreditation system, the milestones, is the last chance for the ACGME to really oversee graduate medical education. So where we are now is that the first CLER visits occurred from 2012 to 2015. Then in 2015 to 2020 was the transition of AOA to the ACGME single accreditation system. And what we're talking about today is the third cycle of the CLER visits, which was June of 2017 to February of 2020, which means it was pre-pandemic. And so what's going to be interesting is to see how the pandemic has affected this. And so there's many articles out there in the New England Journal, the Journal of Graduate Medical Education, that kind of explained the purpose of why we're going through this change. And the article probably that is most pertinent is the clinical learning environment. So we know that how I was trained, the environment that I was trained and those prior is not conducive to producing what society expects. So the ACGME starting in 2013, and since this is a summit on safety, quality, improvement, and high value care, the ACGME in itself is undergoing a continuous quality improvement process. And so whenever you want to look at it, things keep coming down the road in terms of changes, because they're taking feedback on what we're doing and then looking to improve it. So residency training will never be stagnant anymore. And back in the day, you'd get accredited for 3 to 5 years. Now you're only accredited year by year. So there's an expectation that you're upping your game. So what's interesting, and I alluded to this a little bit, change is hardest first, messy in the middle, and gorgeous at the end. And it is going to be very positive at the end. But in my estimation, it's probably going to take 2 or 3 generations of physicians to get where we want to be. And Dr. Gahabe had mentioned this, but as a program director who was lived through these changes, when the ACGME would come out with these things, they would just tell you, you've got to do this, the competencies, the CLER, whatever. And so we felt it was like throwing mud against the wall. And we still think that when things get put in front of us, but it is exciting that instead of being prescriptive, they're allowing us to be innovative. And so one of those innovative things is actually this summit. As far as I know, we're still the only one that does this in the country. And this was based on what Marshall University does, but not, it was that theirs was local. This is obviously statewide. And so what we've run into and where we continue to run to is pushback. And I think that what we discussed about the report will be related to some of that pushback. But just to give you an idea of some of the discussions, and we continue to hear it every day, every time we talk about the change, there's always somebody who's going to say, when I was your age, I walked barefoot uphill and downhill in the snow to get to work. So what I'm going to tell you is those guys are almost retired, so we can't keep using that. So the one I want to tell you that probably is more apropos for the age group here is, when I was your age, I had a flip phone with 250 texts a month, and if I went over, I had to pay for each text. So that's more what I think people will say every time we bring a change, that they don't want the change, they want it to stay the old way. Unfortunately, I'm kind of in between the boomers and the Gen X's. So just so you know, I didn't have a flip phone. This was the first phone that I had, which was called a bag phone. And I bet you probably see this in a museum now. So anyway, getting back to CLER. When CLER was introduced, there was 6 focus areas of the many that are coming down the road that they started with. And so you hear safety, supervision, professionalism, healthcare quality, including healthcare disparities, duty hours and fatigue management, and transitions of care. After the second iteration of the CLER visits, they switched to where well-being replaced the duty hours of fatigue, and teaming replaced care transitions. And those, hopefully everybody's been on a CLER visit, but if you haven't been on one, it's basically a 2-day review where they come in, they have a specific process that they go through, meeting with leadership, meeting with residents and fellows, program directors separately from faculty, and then they actually go walk around the hospital with residents and actually see the clinical learning environment. They talk to nurses, they talk to anybody they can stop and just ask them about things. And then there's a exit meeting where the DIO, the CEO, CMO meet with them, and we get an initial idea of what they found, though about a month later, we will get a report. And I find that report very helpful because I use it for leverage at my institutions to get the changes that we need. So one of the tips is that many times we'll feed the surveyors things that we want on the report so that we can get some leverage. So the report basically was on the 3rd cycle, but what they did was they actually looked at the prior 2 cycles, and they had 242 CLER visits that they could actually follow from cycle 1, cycle 2, cycle 3. They also had 504 visits where they could follow them from cycle 2 to cycle 3. So they did a very in-depth analysis in these 2 types of analyses to come up with what they found. And just so you know, cycle 3 is the first that had well-being in it, which you know, after seeing what it shows, that it's going to have to be a huge focus in this next upcoming cycle. So here were the overarching themes. And first one was that clinical learning environments continue to face significant challenges in changing their health systems at a speed and magnitude needed for sustained improvement in patient care. And there are very few clinical learning environments in which executive leadership effectively engages the GME community in the design of solutions to address these challenges. So there's a huge variation in terms of whether people that really hold the strings, the administrators, engage with us to help improve the clinical learning environment. The second overarching theme, it relates to patient safety and quality improvement. In general, clinical learning environments do not appear to engage all their residents and fellows in the organization's effort to design, evaluate, and improve patient safety and healthcare quality, including healthcare disparities. And that's where I tell you that I think we're ahead of the game as SEMCME in terms of what activities we're doing. And I'm sure it's been mentioned, we're starting the Quality Improvement Scholars Program. We have, advanced and basic training. We have all kinds of things that we're attempting to push the needle on this. And this one, I'm just bringing it up, though I won't focus on it, is that in addressing well-being, many clinical learning environments are focused on individual responsibility and resilience. Few clinical learning environments appeared to address system-based factors that adversely impact the well-being of the clinical care team and the safety and quality of patient care. So in other words, pizza parties don't work. Okay, you got to focus on what's going on in the system, and having these activities is fine, but those are wellness activities. What we had to be focusing on is well-being strategies to make sure that the residents are in a good state. So what I'm going to do is then focus on safety and quality improvement. So here were the major findings for patient safety. In general, residents, fellows, and nurses lack clarity and awareness of the range of reportable patient safety events. And when queried, residents, fellows, and nurses also appeared to vary in their understanding of how clinical learning environments use the reporting of adverse events and near misses, close calls to improve the systems of care. And I think the first presentation was an example of how Ascension Rochester has improved that process so that they're meeting these findings. But as a general rule, most systems are pretty much, we looked at it, at times it'll take 20 minutes for the resident to put a report in. So, that's a barrier. But the other barrier is no feedback. So at some point, you just kind of get to the learned helplessness state where why bother doing it if you're not going to learn or hear anything back from it. The second finding is that a limited number of residents, fellows, and faculty members participated in, and here's the key words, interprofessional, interdisciplinary, system-based improvement efforts such as patient safety events and analyses. Now, this one is a little bit hard because if you had enough RCAs or root cause analysis for every resident to be involved with, I don't think your hospital is providing very good care. So we have to come up with other mechanisms to get them involved with this. And that's a possibility for future QI projects for the residents, fellows, and faculty. So here's the overall 3-point analysis between 2015 to the end of 2021. And what they have here is the desired directional change and then what we're actually seeing. So you can see that non-punitive environment for reporting, experience an adverse event in terms of number of residents reporting that they've seen it, submitting a report, that's gone up, and these are percentages. But then you can see that we've gone backwards in terms of receiving feedback on and reports. And possibly that's due to that we are increasing the number we're submitting and we're overwhelming the system. We're getting a little bit better in terms of near miss and close call events being reported, though I think we still have the problem of people recognizing what a near miss is or close call. And then, like I mentioned, participating in interprofessional patient safety event, we've gone a little bit backwards on that. So you can see that these are things that we need to focus on, and again, could be good projects for you to do in your institution. When you look at quality improvement in terms of the 3-point analysis, again, the desired directional change is to the right, so it's improvement. And here we've gone back even more, where the clinical site priorities, 1.8% less of the residents this time reported that they knew what the clinical site priorities are. About a 2% increase in residents participating in QI project of their own design or one designed by the program. We went backwards about 10% in terms of, are the QI projects linked to the institutional goals? And then we went backwards on interprofessional QI projects linked to the clinical sites QI goals. And then when you looked in terms of the ability of residents to walk out of residency and implement this in their practice, you can see here that 62% stated that they had very few, they had a working knowledge of quality improvement concepts. 26% said they had some working knowledge, and 11% said that they had a working knowledge. So we need to get this subset to this point where they feel comfortable walking out and being able to do this. Then when you look at the type of projects in terms of having a complete quality improvement cycle, only 3% went through a complete cycle. 16% of the projects had some component of the complete quality improvement cycle, and over 80% did not have very many components. So we've got a lot of work to do in terms of preparing the residents for the future. And so when you look at what the expectation from the ACGME is, and it's kind of a waterfall effect. So percentages of residents participating in a quality improvement they designed or one designed the program, about 78% said they did. And then it drops to about 47% when they're asked if it links to one of the clinical sites' quality improvement goals. And then it goes even lower when they benchmark their own performance of what they do with their patients to whatever benchmarks there. Only a third get cultural competency training to identify the health disparities at their clinical site, and then less than 9% of the projects are geared toward eliminating health disparities. So you can see that we need to go the different direction in terms of these metrics. So what have we learned from this report? And this is probably more of the world according to me. If you read the program, common program goals, this is what it says in terms of why you're doing QI. At the end of your training, you're supposed to be systematically analyzing your practice, using QI improvement methods, and implement changes with the goal of practice improvement. So that's what the book says in terms of why we're doing this in residency. But here's the ultimate goal. And if you read the next accreditation system, this is very specific in the first paragraph. The expectation is that physicians that are being trained now are becoming leaders of the healthcare team, and that they will lead the team in terms of improving healthcare, improving population health, improving patient experience, and all the other facets of what needs to be fixed in our broken healthcare system. So what has changed because of COVID? So COVID has really brought out the inequity that exists in the US. If you look at the ability to get COVID testing, the ability to get care, whatever you want to look at, COVID magnified the problem. And so we've moved it to what's called the quintuple aim, where now that equity and inclusion is now the fifth part of the aim, where the first triple aim is basically 15 years old now. Then we added clinician well-being because of the burnout issue we started seeing, and now health equity. So the idea is that the physicians that are trained will be the leaders of the team to help us go to the quintuple aim. I know I was looking at our scoring sheet. We have SMART goals, and we have transitioned to what's called SMARTY goals, because part of the goals when you're doing a quality improvement project is you want to be inclusive now, including traditionally marginalized people integrated into the process, and equitable. And the example I talked about inclusivity is when all the COVID studies for the vaccines came out, there was no pregnant women even considered or underwent the trials. And so when all these vaccines came out, the OB-GYNs and others were left kind of saying, well, what are we supposed to do? So whether it's research or quality improvement, we need to keep those two additional things as part of what we're doing in terms of developing what we want to fix. One of the things that I'd like to bring out as a strategy is that the residents should be being exposed on what the system priorities are. So in other words, is it sepsis bundle compliance? And so what normally happens is the system will have a few very important priorities, they say, for this next year. And for McLaren, this is what we have, what's called the patient safety dashboard. And we track each hospital, we track stretch goals, target goals. Hospitals are compared to themselves, not the other hospitals. And basically, the residents should be able to see what the institution has as focus areas. So here you can see this hospital, Lansing, had more CLABSI events than the other hospitals. This hospital has more CAUTI effects problems than the other hospitals. And so by looking at where the residents are, they can look and see, how can I align my project with what the institution considers as important? So I'm pretty sure that every institution has something similar, and the residents should get exposed to this at least on an every month basis. And so what the best approach is that a department or a program says, okay, we're going to pick this priority or these two priorities, and then the residents align their projects addressing different things. But what happens then is that you've got this cadre of projects moving and trying to help the system and meet its priorities and outcomes. So this is what's called the nested logic model, and it prevents the thing about resident doing a project just to do a project. That there's a purpose and that there's an outcome that really drives improvement. The other thing that we've started working on is that we've recognized that the AAMC came out with this quality and safety competency, that one of the problems that we have is we can't successfully progress medical students into practitioners because we don't really have the teaching and mentorship skills with the faculty. And so that's one of the things that we piloted a QI boot camp for program directors, faculty, and fellows to kind of address that gap. As mentioned, I believe Dr. Gaheba had mentioned in his talk, you got 1 year of being on a buy in terms of Medicare. And then from that point on, you're going to be scored on your quality, and you'll be paid on your quality. And as you can see for 2022, that 15% of that score will be based on 2, 3, or 4 improvement activities you do in your practice. Quality, comparing yourself to all the others in your specialty in the country. And then now there's a bigger focus on cost. How much does it cost you to take care of this patient compared to everybody else? So your ability to have a livelihood is based on being able to show quality. And right now, coming next year, there will be a group of physicians somewhere in the first decile, maybe the second decile, that are going to get paid 9% less than everybody else by Medicare for a whole year. And so that's going to hit you in the pocketbook, and you're going to have to figure out, there's a point where you can't see any more patients. You're going to have to figure out how to deal with that revenue loss. And now, and if you didn't notice this year, we added the title Michigan Summit on Quality Improvement, Patient Safety, and High Value Care, because now it's not just about quality, but it's about cost, and we're going to be paid based on value. And this started in 2006 with Dr. Michael Porter, and it has then gone through numerous iterations where you can see that outcomes were added, and then University of Utah added the perspective from patients, so service. And so the current equation has gotten kind of messy, where now you're getting paid based on quality, you're being paid on service based on outcomes and patient experience, you're being rated on costs, direct and indirect, including patient downstream costs. And then the next thing that's being added is what's your patient access to you, and are you providing the right care at the right time to the right patient in the right place? So value is undergoing this major redefinition. And again, our ability to make a living is going to be based on us showing that we have that value. So quality improvement, and I've really started to question whether we should be calling it quality improvement, but really performance improvement. We're on a journey, and so it's not a race, and it's going to take us a while to get there. And the idea is that you, the residents, will be well trained, and you will go forth and set the world on fire using these tools, these skills in quality improvement. So with that, hopefully I have shown you a direction in which we need to go based on the this most recent report.
So, Bob, thank you so much. Obviously a leader in the field and trendsetter and inspirational teacher and engager, and just a wonderful presentation. And I think we have a few, I know we're a little bit behind, but open up for a few questions to Dr. Flora.
Bob, this is Mike Gabe. I just want to thank you for that really superb summary of kind of where things are at. And at the ground level, if you're thinking about ACGME and all the regulations, and there's so many 24 hours a day, what comes off the plate so that we can pursue this in a organized, clear fashion? In this case, CLEAR rather than CLER.
Well, so all I can tell you is I have an opinion. And what I have learned, and I learned this because I took courses at Michigan State's College of Education, is that the way we train the residents right now, didactics, whatever you want to call it, is highly inefficient. And if you look at the learning pyramid, didactics 5 to 10% retention. Right. We have to change the way we're teaching this group of learners, because they don't go to lectures, or many of them are in their pajamas if they're watching a lecture from home. But we really need to stop thinking about the old way, because what happened, I'm running into a problem, is that they don't want to integrate these things. Like, we have crucial conversations, we have crucial accountability, we're having mindfulness training, we're having team steps training. We're getting a lot of pushback because you're goofing up our curriculum, our educational thing. But one of the most inefficient things is to have a complete class, PGY 1s through 4s in my experience, in the same classroom. And what I did when I was a program director is I built 2 classrooms. I put the interns and first years in one and the 3rd and 4th years in the other. So our teaching methods are so inefficient that we're having a problem getting to these other things, I guess, Mike, that and the faculty, many of the faculty don't think it's important.
Dr. Senstock?
All right, thanks, Bob. It's fantastic presentation as always, and I really appreciate your insights on this. What I find really most concerning and sobering about this is one of the first steps is that residents don't understand and know the priorities of the healthcare system that they're working in. And if this is the case, I just don't understand why we don't fix this. And I must admit, I can't remember ever sitting down at a session where the president of the hospital or the CEO sits down with a residency class and says, hey guys, these are our priorities for the healthcare system, just letting you know. And putting it on a web page is fine, but you never can replace getting the senior leadership in front of the intern class and saying, these are our priorities, these are our problems. Think about this when you're taking care of patients on the floors or in the clinic, and think about this when you're considering projects to do. But again, this is one of the very first steps, which is getting the residents to know what the priorities of the system is. And I don't think we are doing this very initial step in a consistent fashion.
So David, one of the things when I came to Michigan, I was in Ohio. At our GMEC, the CEO, the head of legal were always attended the GMEC so that we actually had line of sight on what's going on, and then we would tell the residents. So I have not been in an institution yet in Michigan where I've seen that, and I've tried to encourage our CEOs to come to the GMECs, and I can't get them to. So I think that's where, that one thing about the engagement of administration, one of the concerns is very visible in Michigan.
Rajiv?
Thank you, Dr. Flora. Yeah, I've noticed, going back to your nested logic model about how do you engage, and just like Dr. Sengstock is saying that, getting people aligned with with the institutional needs. I feel like residents, when residents really commit to a QI project is maybe in their second year. First year is kind of observing, watching. Maybe second year they really own it, and then third year hopefully they own it, but they're moving on to their next step. I mean, it depends. This is internal medicine, of course. So the barriers that I can keep running into are when you do have an institution that has goals that are in line. They hire people to take them on because they're huge, they're big, and they need a lot of attention. So residents like if you take sepsis, for example, sepsis is a huge need for a lot of institutions. So it's daunting for residents to be like, well, what can I do in that setting? Even on a smaller scale, when there's other processes that are being designed towards that goal that I don't have any control over. I don't have a voice to do anything more than education, right? That as a resident, you might feel like, yes, a hard stop, a forced function. I would love to try and do that, but you can't do that at a system level. But EMRs work at a system level. So I feel like they just tend to, we hit a limit on the hierarchy of efforts, the interventions that we can get up to as a resident. Maybe in my clinic I can do change, but that still requires some approval from way up top that, someone's already looking at it who's hired to do that.
So let me tell you one of the strategies. So first, we presented a paper in California that we changed GME to an actual service line. So we're a service line like cardiovascular, neurosurgery, whatever. And so we approach everything based on return on investment. And we have an every other month meeting with all the CEOs We call it the Strategic Governance and Strategy Committee. And these are, we bring those things on and up. And so we have them look at us differently now. And before I got here, they just looked at us like a cost, a money loser. And then I started saying, okay, you're not losing money and this and this and that. And so we're just now starting to see the value of GME in terms of safety, quality, because all they really knew about GME was it was a budget thing on a financial document. But
We have two more questions and for the
sorry.
sake, well, so I don't want to delay Dr. Hannon, but Vesna?
Yes, thank you so much for that presentation, Dr. Flora. I'm excited and scared for the future because I do feel that we're very behind. My experience, for example, with the error reporting project is we've made a lot of changes at the program level and even at a hospital level. And now we're getting some of the feedback that we've heard in the recent couple of months is that we're reporting too much error because there's other departments that don't have the structure to give us the feedback in a timely manner. So I'm seeing that unless part of the planning is really looking at the system that you're practicing in, and does that system support the changes that we want to make and the changes that ACGME is anticipating that we will make in the future. I think as a resident, you have a limited time and you want to do. So you're in that do part of your PDSA cycle and you're really excited about that. But part of the planning, I think, is definitely taking a step back, looking at the system that you are working in, whether it's a community hospital or bigger organization, and does that system actually support the changes that you're trying to make? And it takes it's been a learning process. It's a lot of errors were made during that process and time is spent. So I am a little bit nervous about the future and what changes they expect us to make and how long of a time do we have to do that and to go through this trial and error in medical education.
One of the issues that I brought up in our institution is if you look at your error reporting system, do the program directors and the DIOs get involved in the process? And that's what I've been trying to change because they don't want to let go of it. And so we hear things later on down the road. And that's just a quirk with quality people. They like control. But where I came from when I was with Ascension Providence, when a report was identified as a resident, it came to the program director, and then the program director escalated it to me. That's how you get that feedback. And then that's how your faculty get trained in terms of how to address those things, because the quality department does not, and the safety people do not have enough time in the day to do what they expect. So let us do it.
Absolutely, and time is a major concern for our faculty, and that's the process that we have here. But we're getting feedback from other departments, like if an error includes the emergency room, an emergency room doesn't have the structure to have one person going through their error reporting and giving feedback to the residents. So now they're overwhelmed with reports that they don't have responses to because they don't have the staff that or the dedicated time for that they're paying a certain individual to do this. And it's not incorporated into their budget and their responsibilities. And as you know, our responsibilities just keep on adding on. But there's only, as someone mentioned, 24 hours in a day. So it's, thank you for that feedback.
Yeah. Camille, just one last quick question. Camelia?
Yes, thank you. Thank you for the opportunity. Hello, Dr. Flora, so good to see you. I have a quick question. I know we talk about ACGME and graduate medical education, but I do feel like some medical schools right now, they have this integrated longitudinal curriculum, right? So I was wondering what's your insight and can that be, kind of be extended? So because the residents come from different backgrounds, they have different experiences. So in order to make sure that they have a meaningful experience in regards to applying practically the QI principles, I think they should get that at least a basic knowledge and maybe get involved at the medical school level. And I don't think all medical schools have implemented that. So what's your insight? Thank you so much. Appreciate it.
Yeah, so Dr. Arsene, you're 100% right. And I'm actually on Michigan State's LCME committee looking at it. And just like anything else, there's just not enough time in the day. But there is a push from the AMA in terms of health system science, or HSS. There's actually a textbook that's been released, and the national board has an exam on health system science now for medical students. I think the problem is that people are trying to figure out how to integrate that in. And at this point, the NBME exam on this is optional. But I think they'll have to make it a requirement, because you can't walk out of medical school and then we're trying to teach them in their intern year this stuff while they're trying to learn how to be a clinician. It's just not effective or efficient. But there is activity being done, and they're titling it a health system science education for medical students. And the text is excellent, by the way.
Bob, thank you. Could you please, we need to move on, and greatly, again, wonderful presentation. Thank you. Could you please introduce Dr. Hannon?